Hello and welcome to chapter 16. In this chapter, we'll be discussing altered perfusion. So in order to start talking about perfusion, we first must know what organs we're working with. So anytime we're talking about perfusion, more specifically, it's dealing with the heart and the circulatory system, but there is a layer of the lungs that will be at play here. But again, we are looking at the heart and the blood and how it goes to different organs throughout the body. So the definition of perfusion is the forcing of blood or other fluids to flow through a vessel and into the vascular bed of tissues to provide oxygen to organs and the organ systems throughout the body. So blood is forced through the heart and the circulatory system. So again, these are working in tandem to help perfuse or provide oxygen to the organs and tissues and thereof in the body. So we have to have the circulatory system working in order for our bodies to get the oxygen that it needs to our different organs. So perfusion is the method by which the body stays alive. Just as a review, we have the anatomy of the heart, and I just want to talk briefly about what the layers are in the chambers. So we do have three different layers. We have the pericardium, which is the outside layer of the heart. Then we have the myocardium, which is the muscular layer. And then we have the endocardium, which is the inner lining. And sometimes we have alterations in these areas that could cause issues later. In this lecture, we'll discuss a little bit about that. And then we have the chambers of the heart, and we have the right and left atria. And if you don't remember, the atria are literally the top part of the heart. And then we have the ventricles, which are generally in the bottom part of the organ. So now that we learned a little bit about the layers of the heart and the chambers of the heart, let's talk a little bit about what happens with circulation. And we have three different types of circulation that happens normally in the body. So the first one we'll talk about is pulmonary circulation. So again, we are talking about the concept of perfusion. This is the process by which we're getting oxygen to the tissues and the organs of the body. So the question is, how do we get oxygen? Well, that's from breathing. When we breathe in, oxygen sits in our lungs. When we are trying to transport that oxygen to the blood, we have to do that through pulmonary circulation. And this is simply the circulation through the lungs that provides the ability to transfer oxygen from the atmosphere into the body's blood. So this occurs when the blood is carried through the pulmonary artery. So pulmonary arteries have deoxygenated blood, so there's no oxygen in the blood. Once the pulmonary artery carries the blood inside of the lungs then gives that blood oxygen because there's oxygen sitting in the lungs from the atmosphere. So the lungs then give blood, that oxygen, and then that oxygenated blood is now carried through the pulmonary veins to the left side of the heart. And once we reach that left side of the heart, we now have oxygenated blood, and now it's going to work to be squeezed through the aorta to the rest of the body. So this is the process by which we get oxygen into the blood circulatory system. Now, we're going to talk about systemic circulation. And systemic circulation is where we now have oxygenated blood, but now this oxygenated blood has to get to our tissues and organs in order for them to have the oxygen they need to survive. So that occurs when blood flow through the heart muscle pumps oxygenated blood to the body, and normally this is going through the aorta, and once it's going through the aorta, that's where it's distributed through the body. So systemic circulation is really powered by the left ventricle. As I've mentioned with the pulmonary circulation, eventually that oxygenated blood goes through the left side of the heart. Well, once it reaches that left ventricle, the left ventricle squeezes really hard, and that's the most powerful part of the heart, the left ventricle. When that left ventricle squeezes, it shoots that blood that's oxygenated through that aorta, and then that oxygenated blood goes throughout the body. So again, this is how the body gets perfused with oxygenated blood. So it must go through pulmonary circulation first, and then it switches over to systemic circulation, and that's how it gets through the areas that it needs. So now we have coronary circulation, and this is really the perfusion of the heart. So you have two major vessels, the right coronary artery and the left coronary artery, that help perfuse the heart. So the heart must itself have its own oxygen supply. So the heart's working two ways. It's getting oxygen to the body to perfuse those organs and make sure they have oxygen, but the heart also needs oxygen because it's also an organ. So it does this itself through coronary circulation. So again, this is a brief overview of these concepts. Just understand that we have to have pulmonary circulation, systemic and coronary circulation in order to be perfused well. Here's a reminder about our cardiac cycle. I just want you to be aware of what's going on and where blood is being oxygenated versus where it's not being oxygenated. So you go through the venous blood system, the blood is returning to the heart, and then that blood that is deoxygenated enters the heart through the right atrium. Then it goes through the tricuspid valve into the right ventricle. So we're still on the right side of the heart. That blood must go through the pulmonic valve into the pulmonary artery. So again, when we hit that pulmonary artery, that's deoxygenated blood that would eventually become oxygenated through ventilation, perfusion exchange. So we are breathing in the blood is in the lungs, getting perfused with the oxygen that has been obtained from breathing in. Then you have now oxygenated blood. This is where we have that switch. So it goes to the heart through the pulmonary vein, and then that blood goes through the bicuspid valve into the left ventricle. So once we go through the left ventricle, we go through the aortic valve to the aorta, and then at the point of the aorta, that's where we have the contraction from that left ventricle. All of the blood is going through the aorta, causing systole. That is what we know as our heart contraction. It systemically goes throughout the body, and then once that blood has gone to every organ and it has perfused those organs, we have something called diastole, and that's where the heart contracts. Well, relaxes, excuse me. The heart relaxes, and then we now have the oxygenated blood returning back to the heart to then be oxygenated again. So again, this is just a reminder of your cardiac cycle. The main thing I want you to understand is that the blood must go back to the lungs in order to be oxygenated. Again, perfusion does not occur if you do not have adequate ventilation. So this is a critical part here. Deoxygenated blood must become oxygenated in order for perfusion to be effective in the body. So here we'll talk a little bit about impulses. The heart runs on an electronic system or electric system. And this is dealing with action potentials that stimulate that contraction and relaxation in the heart. So we have different phases. We have depolarization, repolarization, we have the plateau, we have rapid repolarization and a resting phase. So the heart cycles through this constantly without you having to stop and say, hey, heart, I need you to pump now. Hey, heart, I need you to pump now. This all happens simultaneously, and you do not think about it because of that cardiac center in your brain. So just know that there is impulses that are occurring with the heart that's stimulating these contractions automatically and causes the blood to move systematically without you having to think about it. We do have something called an electrocardiogram, and this is also known as your EKGs. So this is just a simple breakdown of your EKGs and the waveforms thereof. We're not going to go into detail about the telemetry strips and what normal sinus rhythm is versus what a dysrhythmia is compared to a normal sinus rhythm. But just know that you do have these waveforms that we look at for normalization of the heart conduction. If we have abnormal heart conduction, then that would speak to why we're not perfusing very well. So again, we do have P waves, we have PQ intervals, QRS intervals, we have the T and the U. So just understand that when we look at these, we're really looking for abnormalities in the conduction system of the heart, because that'll tell us a lot about what's happening with the perfusion of an individual. I will give you one simple example, and you can look up what the dysrhythmia is, but it's not necessary for this course. But you a heart normally contracts in normal sinus rhythm when there's no abnormalities. You call that normal sinus rhythm or sinus rhythm in some textbooks. When you have a dysrhythmia or arrhythmia, the absence of a rhythm, or you have an abnormal rhythm, dysrhythmia, you have different conduction impulses. So in the case of atrial fibrillation, that is something that's an irregular impulse. And there's no clarity with atrial fibrillation, but one of the clinical implications of atrial fibrillation is that normally those pressures can be lower in individuals with atrial fibrillation because the atria are vibrating, they're not contracting well. And you have different variations of atrial fibrillation. You have atrial fibrillation controlled. You have atrial fibrillation with RVR, rapid ventricular responses. Again, these are just dysrhythmias of normal sinus rhythm. So what that is telling us is that because atrial fibrillation looks different on an EKG strip or electrocardiogram strip, we know that there's a problem with the conduction in the heart, and therefore we can expect some perfusion issues with the individual with atrial fibrillation. So again, you can look up what those strips are. It's not required for this particular course, but I do want you to understand that's why we look at EKGs and electrocardiograms. So now we'll talk a little bit about the conduction system of the heart. We talked a little bit about a EKG or ECG, electrocardiogram tracing. Well, all of that is based on the conduction system of the heart. So you have different nodes in the heart that help conduct the electricity that helps the heart contract. So that electrical pulse must first go through the sinoatrial node, which is technically kind of like your pacemaker. So this is what stimulates the heart and is most consistent. And it is supposed to be one of the stronger forces with being consistent with your heart's rate. So anytime we're talking about heart rate, we're talking about how many beats per minute this SA node contracts. So it must first go through the sinoatrial node, and then you go to the AV node, and that is your secondary point by which the electricity is pumping through the heart. Then it goes through the bundle of His, and then you have your right bundle branch, and then your left bundle branch, and then finally you have your Purkinje fibers, which is located more so at the end. So when you have the conduction system of the heart, we are looking at EKGs to see how well your SA node, your AV nodes, and things thereof are contracting. Well, when you do have alterations in the heart and the conduction system, sometimes that SA node is weakened or it doesn't work that well anymore. So then the heart automatically moves on to the next strongest pulse conductor, which would in this case be your AV node, and it goes on and so forth. So when you see alterations in your EKGs or you see different blocks like an AV block, things like that, that means that your heart's conduction system is weakening progressively. And at that point, that's what you see traced on your EKGs. Now, for the purpose of this class, we're not necessarily going over telemetry strips, but just know that when you do look at those telemetry strips and those EKGs, that's what you're looking at. You're looking at what is happening compared to what's considered normal sinus rhythm in the heart. So now we'll talk about some of the requirements for effective perfusion. So again, we are talking about getting oxygen to our tissues and organs and what's required for that to be effective. So you have to have adequate ventilation and diffusion. In one of the previous lectures, we talked a lot about what ventilation is and what diffusion is and how breathing helps maintain homeostasis in the body. So that has to be adequate in order for you to have effective perfusion. You have to have adequate oxygen stores in the body in order for you to perfuse well. Then you have to have your pulmonary circulation intact. Again, that is the process by which not only we're breathing in, but that's how the oxygen is distributed to the blood, which would then go to the rest of the body. So that circulation has to be adequate in order for you to have effective perfusion. You have to have adequate blood volume and the components thereof. So not only is it enough for you to have enough blood content, but you have to have enough plasma, you have to have all the components of blood in order, the fluid side of it as well. You have to have all the components of blood in order for you to have effective perfusion. And think about that for a second. If you're not having enough blood volume, you don't have enough blood that needs to circulate or to distribute to all of the organs in your body. So you have to have enough volume of blood in order to perfuse well. You have to have adequate cardiac output, and that has a lot to do with that squeezing of the heart that we talked about. So the left ventricle has to squeeze effective enough, or it has to have enough cardiac output in order to push that blood volume that we just talked about to the rest of the body. So it's very possible for you to have enough blood volume, but if your cardiac output is not strong enough, then that blood is not reaching your organs. So you have to have adequate cardiac output for effective perfusion. You have to have an intact cardiac control center. That means in your brain, your heart pumping is an automatic process. You don't stop and tell your heart to pump. It does it by itself, similar to breathing. You do that by yourself. You have a respiratory center and a cardiac control center in your brain. So if that's not intact, you have some type of neuro damage, or it damages that cardiac center or the respiratory center, you're not going to have effective perfusion. So that leads me into the parasympathetic and sympathetic nervous system. Again, your heart and your neural system are very, very much conjoined. So when you don't have adequate sympathetic systems, whether it's sympathetic or parasympathetic, you're not going to have effective perfusion. Again, your circulations, all three of them have to be well. So your cardiac, your pulmonary, and systemic has to be working well in order for you to have adequate perfusion. And again, once all of these processes have occurred, say that you breathe well, say that your heart is pumping well, say that you have enough blood volume and things that are necessary for perfusion, the organs have to take the oxygen from the blood. So you have to have adequate tissue uptake of oxygen in order to perfuse well. So these are all areas that you could potentially have alterations in perfusion, because if they don't work, that's where you'll see manifestations or clinical manifestations of ineffective perfusion. So now we'll talk a little bit about ventilation with perfusion together, and recall that ventilation is literally the process of inhaling oxygen and exhaling carbon dioxide. So we talked a lot about that in chapter 15 and what the implications are with ventilation. So in perfusion, we are assuming that ventilation is adequate. And recall that in order to perfuse the body, you have to have adequate ventilation, because that's the process by which you're getting oxygen. So we do look at a ratio called the VQ ratio, V for ventilation, Q for perfusion, respectively. And this ratio generally tells us how well the body is perfusing, or if the ratios are generally where they are supposed to be. So for the purposes of this course, I just want you to know that the ventilation perfusion ratio is 0.8 to 0.9 respectively for ventilation and perfusion. And generally, you'll see that the rate of ventilation is less than that of perfusion, which makes sense because nothing's perfect and it's never going to be necessarily equal. There's always going to be a little bit of a variance there. So again, 0.8 ventilation to 0.9 perfusion respectively. And if you see anything with V, that means ventilation. And if you see anything with Q, that means perfusion. Overall, the main point is that you cannot have adequate perfusion without adequate ventilation. In fact, ventilation must occur and must not be deficient in order for perfusion to be effective and for your organs to remain viable. So we've talked about how we have a ventilation perfusion ratio. So a lot of pathophysiology is talking about what is going wrong with the body. So again, we are talking about the alterations with perfusion in this lecture. So one of the alterations is ventilation and perfusing mismatching, or a VQ mismatch for short. And again, effective gas exchange relies on the adequate intake of oxygen and the movement of this oxygen to the organs in the body. So when we have a VQ mismatch, a ventilation perfusion mismatch, we have two different things that could occur. We could have perfusion, so the blood is going, but it doesn't have any oxygen. So that is called perfusion without ventilation, when you have blood that continues to move through the systemic system and systemic circulation, and there's no oxygen in it. So that is called shunting. And you see deoxygenated blood going to tissues and organs, which would eventually cause organ death and death of those tissues, because you're not perfusing them very well if this goes on long term. So you have lesser cases of shunting. You have pneumonia or pulmonary edema. And again, this is where you do not have perfusion because there is no oxygen getting to these organs in the body. The next one that we'll talk about is no ventilation. Excuse me, we'll talk about ventilation with no perfusion. So we have oxygen exchange, which is adequate. So ventilation is working in this particular issue, but the oxygen is not making it to the organs. So this is called dead space. And this is literally where we have ventilation that does not get to the organs or tissues in the body. And an example of this would be a pulmonary embolism. So we have ventilation that's occurring, but with the pulmonary embolism, that is a clot, that blood is not moving past that clot. So we have adequate oxygenation up until the point where the clot is, and that blood is no longer moving past the clot. So that is a pulmonary embolism in its most simple terms. But again, with VQ mismatching, you do have these two disorders, which is shunting and dead space. So make sure you understand the difference between shunting and dead space. Shunting is where you have perfusion without ventilation, and dead space is where you have ventilation without perfusion. Next, we'll talk about cardiac output. And cardiac output is simply a measurement of the heart's efficiency to pump to the rest of the body. And it's based off of two factors. You have the stroke volume, which is the amount of blood pumped out of the left ventricle in one beat. So this is looking at how well the ventricles are pumping. And then you look at something called the heart rate, and this is the number of heartbeats in a minute. So they have a direct relationship with cardiac output. If your heart rate increases, your cardiac output increases. If your stroke volume increases, your cardiac output increases. So the relationship of these values are represented in this formula listed on the slide. We have stroke volume times heart rate, and that'll give us what our cardiac output is. So next we'll talk a little bit about blood pressure, and this is the tension of blood within the systemic arteries of the body. So we're talking about how blood is flowing through the body, and we're talking about how well it does that. So blood pressure is a measurement of that, and it is affected by several factors. That includes contraction of the left ventricle. So is the blood even making it to the body anyway? We have peripheral vascular resistance. So is the blood able to travel through the vasculature well? Do we have the elasticity of the arterial walls? So are the arteries flexible enough to widen when the blood comes through? And we also look at the viscosity of the blood as well as the blood volume. And when we discuss viscosity, that is the thickness of the blood. Yes, blood can be a little bit thick or thin depending on what types of medications you're on. And we have the blood volume. So if you have enough volume or blood amount overall in order to have effective blood pressure. So when we look at blood pressure, we're looking at the systolic and the diastolic measurements. When we talk about systolic, think about systolic is the system. So this is the amount of pressure that is exerted during the contraction of the left ventricle and ejection of the blood into the aorta. So again, when blood moves into the aorta, that is the point by which the blood is distributed through the rest of the body. So the systolic number measures how well that is performing in the body. And then when we look at diastolic, that is the amount of pressure remaining in the aorta during the resting phase of the cardiac cycle. So we look at these two values as it relates to blood pressure because it tells us a lot about perfusion and how well the body is tolerating what's being held through the heart. Now, when we look at blood pressure, this is one of our vital signs. So when we have an increase in blood pressure, we know that the body's contracting a little bit too well, and that could be causing stressors on the heart and the circulatory system as a whole. If we don't have a lot in our blood pressure, or if we have low blood pressures, we'll see the manifestations of that. Oh, maybe something's wrong, or maybe that individual doesn't have enough fluid volume. Maybe there's some type of blockage that can, or maybe even the heart is failing. So blood pressure is one of our vital signs for a reason, because it's an indicator of how well the body can perfuse or is not being perfused. Another way that we measure perfusion specifically, though, is through a value called mean arterial pressure. So this is the measure of systemic tissue perfusion, and normally it is equal to 1/3 of the pulse pressure plus the diastolic pressure. Now, for the purposes of this class, I'm not going to make you do calculations on the mean arterial pressure, but just know that anytime someone speaks of the mean arterial pressure, or the MAP, it is a direct correlation of the perfusion in the body. So with that being said, let's talk about MAP and what's an acceptable value. Normally, you want a MAP of 65 or greater. Generally, when you see MAPs below 65, and it may depend on the clinical condition that you're seeing, but generally below 65, you're not perfusing the body as well as it should, and that could lead to complications down the road. So whenever you look at the pressure, you're not just looking at the systolic and the diastolic number. You also want to calculate, or at least look at, the mean arterial pressure and see if the blood pressure that is presented is perfusing the body well. So we talked a lot about how the circulatory system is closely mapped with the neurological system, in that the body automatically adjusts itself based off of sensory, based off of things that are stimulating it with the body. And ultimately, the body does not have, or you don't have to tell your body to pump the heart and for it to then circulate through the body. It does that automatically due to your cardiac center. So the cardiac center is in the same general area as your respiratory center, and that's in the medulla and the pons. And we have two nervous systems that act on our blood pressure. So we have the um, sympathetic division of the nervous system, and that increases blood pressure and heart rate. And again, this is in response to maybe a fight or flight response. Whenever we activate the sympathetic nervous system, we're shunting blood into the heart and from non-essential organs in order to either have a fight response or be able to run away or have that flight response. So when we look at sympathetic, it increases heart rate, it increases blood pressure. When we look at parasympathetic, it decreases heart rate and it decreases blood pressure. So again, your neurons, your body is responding automatically to these sensory things in the outside environment. Now, how are these regulated? We do have neuronal mapping to this regulatory system with blood pressure. So we have something called baroreceptors and chemoreceptors in the arteries that help with regulation. So this is where you see most of that sympathetic activity. If your baroreceptors are stimulated well enough, it will stimulate the sympathetic nervous system, and it could cause your blood pressure to go up simply because your baroreceptors are triggered. We also have a system called the RAS system, and we will watch a video about RAS. But these are hormones that are acting on the kidneys to help stimulate blood pressure. And it is a little bit complex in that not only is it stimulating blood pressure, but it's also regulating fluid because we're dealing with the kidneys. But the renin-angiotensin aldosterone cycle works on blood pressure because of that fluid regulation, and then ultimately the kidneys are associated with that. So again, we do have neuronal control of blood pressure, and the body automatically adjusts itself depending on what's going on in the outside environment and how the body is being triggered. So again, we have the concept of what alterations are, and again, that is what's wrong with the body. So when we have altered perfusion, chances are there's an issue with ventilation as well. Or it could simply be at the perfusion point. Maybe we are being ventilated well, but it's just not making it to the organs. So that could be ventilation perfusion mismatching. It could be impaired circulation as a whole. It could be inadequate cardiac output, or you could have everything working, but you have such excessive demands on perfusion or oxygen requirements that your body is not able to keep up. So all of these are areas that you can have altered perfusion. So when we talk about ventilation perfusion mismatching or VQ mismatching, that's either shunting or dead space. When we shunt, we do not have adequate ventilation, but we have adequate perfusion, so that's a mismatch. Or when we have dead space, we have adequate ventilation, but it's just not making it to the organs of the body, so therefore perfusion is hindered. Um, so again, just recall that ventilation is required to perfuse the body with oxygen. So when we have VQ mismatching with those two issues, that's where you would see an alteration in perfusion. As it relates to impaired circulation, you can have several issues that are related to impaired circulation. That could be an obstruction to circulation, so a physical blockage of that blood vessel. And you normally see physical obstructions with thrombosis, atherosclerosis. You can see that with aneurysms where the vessel is split or has burst. You can have venous stasis where you don't have that return of the blood where it needs to go. You can have too much clotting in the body. You can have embolisms in the body, and you can also have an infarction. So all of these would be issues that are related to impaired circulation in the body. You can also have a hemorrhage. So that's physical injury to the blood vessels that would then perfuse the organs. So that circulation has essentially been cut off and damaged to where that oxygenated blood does not make it to the tissues and the organs that it needs to go to. You can have inadequate output, and again, that's related to changes in blood. Maybe your left ventricle does not pump very well. You could have structural defects on the heart. You can have conduction defects, which would relate to your arrhythmias or dysrhythmias, or you can have changes in your peripheral vascular resistance. So again, inadequate cardiac output is directly related to that. And then your excessive perfusion demands. So again, your body could have too much requirement, or you need too much oxygen to deal with certain things in your body, and you don't have enough ventilation power to meet the perfusion demands, and that will also cause a alteration. But one of the main ones I do want to talk about is Virchow's triad. And when you have Virchow's triad, this is where you see a lot of your impaired circulation issues. In order for you to get a thrombosis, these are things that normally happen that lead to thrombosis in the body, or clots. So you could have vessel wall damage. You can have excessive clotting factors or excessive clotting, or you can have alterations in blood flow, such as too much blood flow or very slow blood flow. Anytime you see any of these three issues, and most times they happen in a triad, that's why they do call it Virchow's triad, you most often see a thrombosis form or clot form. So again, when we see these clots, that impairs circulation and ultimately causes alterations in perfusion. So if you don't remember anything else, understand what Virchow's triad is and how that impairs circulation. Next, we'll talk a lot about the clinical manifestations of altered perfusion, and you'll see these appear again and again. So just understand what these are as a whole and conceptualize that. So the first one we'll talk about is cyanosis, and this is the bluing of the skin. So you'll see a blue hue or maybe a gray hue on darker individuals, but this is where you're not getting oxygen. So the body turns blue. This process is called cyanosis. You also have pain, you have paleness or pallor, you'll have coolness to those extremities or areas that are not being perfused. You may even see edema or swelling in these individuals that do not have adequate perfusion. You'll see shortness of breath or dyspnea, impaired growth, tachycardia or high heart rate. You may see tachypnea, which is high respiration rate. You see fatigue, hypotension, which is low blood pressure. You may see hypertension, high blood pressures. You'll see bleeding and bruising, and you'll also hear heart murmurs. So again, these are all generalized clinical manifestations, and they could lead to any of the alterations that we'll discuss. So you'll have to compare that to what condition it is. But just understand that these could all point to altered perfusion issues. So here's some generalized diagnostics and treatment for altered perfusion. First, we'll start with the diagnostic tests. You'll see individuals with cardiac perfusion issues get echoes or echocardiography. You'll see catheterizations. Cardiac caths is what you'll normally hear with this, and this is literally the widening of the vessels that are affected by blockages. You'll see chest x-rays, EKGs, those are your EKGs or ECGs, those are the same thing, and those are your telemetry strips, or you're looking at telemetry to see what the heart is doing and how the conduction system is working. They'll look at the pressure. You'll do a stress test, which basically simulates, you can have this medically done, but it basically puts stress on the heart to see how well it tolerates active movement. You can do nuclear scanning, or they'll do Dopplers. As far as treatment, you'll see surgery, pharmacologic treatments, and that depends on the condition of the different pharmacological drugs. You'll have pacemaker interventions. You may see different types of intravenous fluids, and also lifestyle changes would help treat issues with cardiac perfusion. So here are our clinical models as it relates to altered perfusion. We'll look at hypertension, shock, myocardial infarction, heart failure, stroke, and disseminated intravascular coagulation. So let's discuss hypertension first. And this is basically high blood pressures. And this is a progressive syndrome. Sometimes it's not detected until later. People don't necessarily know they have hypertension if they're not taking their blood pressure regularly. But it is a progressive syndrome that is detected by elevation in blood pressure or the presence of organ damage due to the persistent blood pressure elevation. So after a certain point, hypertension can become not good for the individual, and it can become deadly because of persistent tissue perfusion. So you have to think about what hypertension is. Hypertension is elevated blood pressure, so that means you're hitting your organs and maybe hitting your organs too much with blood, which causes inadequate perfusion. So you do have primary hypertension versus secondary hypertension, and there are multiple risk factors, which include family history, aging, ethnicity, particularly with the African American race. This can be associated with your nephrons or kidney issues, diabetes, excessive dietary intake of sodium. It can be caused by a sedentary lifestyle, obesity, and excessive smoking and alcohol intake. Your clinical manifestations are symptomatic, asymptomatic, and early stages. So you may not even know that you have hypertension at first, but when it advances, you'll see more neurological issues such as headache, blurred vision. You may have some abdominal issues such as nausea, vomiting, and weakness, maybe fatigue and confusion. Maybe you'll have some altered mental status depending on how severe it is. And it can also cause stroke because your pressure is too high. You can see cardiovascular changes with heart failure and pulmonary edema. And you'll also see some renal insufficiency as it relates to poor urinary output, or you may have some issues eliminating your urine. You may even see blood in the urine or more proteins in the urine. As far as your diagnostic criteria, you have to have a history and physical examination. You'll do your blood pressure measurements and you'll look at laboratory studies. And then once it's diagnosed, you can be placed in different classifications of hypertension. So you can have pre-hypertension, which is 120 systolic to 139 systolic, 80 diastolic to 89 diastolic. You have stage 1 where it's 140 and greater up to 159. Diastolic is 90 or greater up to 99. And then stage 2 is greater than 159 and 99 diastolic. So with hypertension, you do have different classifications. Ideally, you want an individual's pressure to be 120 or a little bit less than that. Now, there is the alteration of hypotension, but we won't necessarily discuss that at this particular point in the lecture. But just know that with this clinical model, hypertension has several classifications, and ideally you want to maintain someone's blood pressure at the 120 over 80 mark. As far as treatment, you have multiple antihypertensive drugs, but one thing you want to focus on with your patients is prevention, and you also want to include lifestyle modifications. So that would mean weight reduction, decrease alcohol intake and smoking. You want to encourage decreased salt and fat intake. You want to encourage exercise and physical activity, fruit and vegetable ingestion, and again, smoking cessation. So this is your clinical model of hypertension, and this is how we normally deal with that in the clinical setting. So the next clinical model is shock, and we have several different types of shocks that we know about, and the etiology really depends on what type of shock that you're experiencing. So overall, shock is a condition of circulatory failure, and it results in impaired perfusion of vital organs. So there are different sources of impaired perfusion. You have cardiogenic shock, which is ineffective cardiac pumping. You have hypovolemic shock, which means you don't have enough blood volume to circulate. You have septic shock, where you have a bacterial infection that's causing circulatory failure. You have neurogenic shock, where you may have a spinal cord or brain injury that's causing circulatory failure. Or you may have anaphylactic shock, which is an allergic reaction that can also cause circulatory failure. So again, all of these are different types of shocks that would result in similar symptoms of shock. But again, it just depends on the source and the etiology by which the shock has occurred. As I've mentioned, all types of shock deprive the cells of oxygen and perfusion and nutrients, and therefore it impairs cellular metabolism because you're not perfusing anything. Your cells are not getting the oxygen that they need in order to survive, and this ultimately results in some sort of acidosis. So the body will initially try to compensate um, for the shock initially occurring. So the body may shunt blood to the heart and brain, which would help produce more perfusion that way, or it may promote cardiac output by trying to increase intravascular volume. Sometimes your body tries to compensate by adjusting the heart rate and contractility of the heart, or the pumping of the heart, because your body does not just allow shock to occur. It does try to combat it with these areas. So again, the body will either shunt blood to the heart and brain to help with perfusion, or the body may attempt to increase cardiac output by increasing the heart rate and increasing cardiac contractility. So you'll see these compensation mechanisms to try and reverse the shock. But sometimes, most times, this is a temporary fix, and the body is not able to sustain and maintain this compensation method. So unfortunately, if the body is not helped outside of what it can do, you'll see a decline, and ultimately that shock can result in death due to inadequate tissue perfusion. So some of those clinical manifestations that indicate compensation of the body is tachycardia. That is an effort for the body to to increase cardiac output and contractility. You have tachypnea, which is the body trying to increase its respirations in order to get more oxygen in the body for perfusion. You may see individuals have cool and clammy extremities. You may see a weak peripheral. Again, I mentioned that this is a medical emergency, so you want to um, activate the airway breathing circulation method. You want to make sure that the individual that's experiencing shock, they still have an airway. So you may see these individuals intubated immediately to protect that airway. And they may they will be immediately placed on a ventilator to help them breathe, because now their systems have started to shut down. So maintain their airway. You want to make sure they're breathing, and then you focus on circulation, which is the whole point. The person is not perfusing well if they have shock. So once you establish airway and breathing, then you focus on how can we get the heart pumping well enough to help perfuse the organs of the body. So again, treatment depends on the type of shock. Hypovolemic shock, for example, depending on if they lost too much urine or just volume overall, you may see blood transfusions happen emergency for a person with hypovolemic shock. Particularly with that case, you'll see that in individuals that have traumatic wounds, gunshot wounds that are bleeding profusely, or individuals that were in bad car accidents. You may see them go into hypovolemic shock because their blood volume has decreased due to the extent of their injuries. So a type of treatment for that would be to increase their blood volume, give them fluids, and give them blood to help increase the volume of circulatory blood accessible to them. In the case of septic shock, you will treat with fluid boluses. Depending on which type, you may see normal saline or lactated ringers, depending on what's going on with the patient. But in the case of septic shock, you're trying to dilute that pathogen that is affecting the blood system that's causing these detriments to the organs. So again, you have different types of shock. It depends on the type, but just know that shock is a medical emergency and that it should not go left untreated. So next we'll talk about myocardial infarction, or MI. And again, when a patient comes in with this, you do not want to take it lightly, because a patient can deteriorate rather quickly with myocardial infarction. So the pathophysiology behind it is that it is the total occlusion of one or more coronary arteries, which causes ischemia. And ischemia means that the tissues are not being perfused, and eventually, if they're not being perfused, that muscle or those tissues, they die. So once you have death of myocardial tissues, that causes other alterations. So you don't want tissue death in the heart, because they don't come back after that point. So again, you have the pathophysiology is there's a occlusion, maybe a thrombosis or embolism in the coronary arteries, which result in ischemia. Atherosclerosis is the most common cause of myocardial infarction. And risk factors include family history of coronary artery disease, hypertension and smoking, elevated cholesterol levels, diabetes, high sensitivity, C-reactive protein, or your CRPs, are always elevated, and also hyperhomocysteemia. So with myocardial infarction, again, you do not want to let these symptoms go by unchecked. Men present a little bit differently from women as far as your clinical manifestations are concerned. For example, women that are having a myocardial infarction, they will feel issues in their jaw and their back, but not necessarily left arm pain. Whereas men, they generally experience it in their left arm, and they have the pain in their chest, and they may even see issues in the jaw or shoulder area. So again, if someone is complaining about any of these manifestations, you want to get them treated immediately, or at least get the assessment work going immediately, because if it is left unchecked, you are dealing with heart tissues. If they die, they do not come back, and that causes other alterations with the patient. So you do have left arm shoulder pain, jaw pain, fatigue, weakness, syncope, which is fainting, anxiety or apprehension, dizziness, shortness of breath, sweating, which is diaphoresis, pallor, paleness, indigestion, nausea, and vomiting. And again, that chest pain. Normally this chest pain is crushing and that pain hurts really, really bad. And normally they'll rate it a 10 out of 10 and it radiates to that left side, shoulder, or jaw. Anytime anybody tells you that, again, make sure you address it immediately. As far as your diagnostic criteria, the presence of symptoms, you have to have a history and physical examination by the healthcare provider. They'll do a lot of cardiac enzyme studies on CK or CK&B troponin levels on individuals that have myocardial infarction symptoms. They'll do an EKG or ECG. You'll see an echo or chest radiograph or angiography, and all of this helps you look at the vessels of the blood and look at the dilation of the heart or enlargement of the heart to see what's going on and seeing if there's any stress that has been made as a result of these signs and symptoms. As far as your treatment, it is emergency management. Chest pain 10 out of 10 could quickly deteriorate. An individual that tells you that could potentially be having a severe heart attack, and they could be on their way to being pulseless. So you want to treat it as a medical emergency every time. Always ensure that airway, breathing, and circulation are followed. As far as surgical management, you may see PCIs or PTCAs completed on these individuals, which help widen the vessels that are affected, which would help restore perfusion. You may see stents placed in those arteries to help open it up to get blood circulation flowing again. As far as long-term treatment, they do need lifestyle modifications as the same way that individuals with hypertension would. You want to make sure they're not having a sedentary lifestyle, that they're eating good, reducing their sodium intake and things thereof. As far as pharmacological methods, it depends on the severity of their myocardial infarction, but they would definitely have pressure medications as well as contraction medications to help with the heart. So again, with myocardial infarction, this is your clinical example of that, and just make sure when you're in the clinical setting that you're paying attention to these signs and symptoms. So next we'll talk about heart failure, and this is the point where an individual has had so much damage to the heart that it starts to not be efficient. So this is directly related to the inadequacy of heart pumping. So the heart is not pumping well enough to maintain circulation, which affects perfusion. And it is the result of an MI. It can be the result of impaired cardiac functioning or excessive workload demands. There are two different types of heart failure, and their clinical manifestations will vary based off of the type of heart failure that you have. The first one we'll talk about is left-sided heart failure. So you'll see a decrease in cardiac output. So you may see decreased stroke volumes. You may see decreased heart rates in an individual with heart failure. You'll see pulmonary congestion. An individual with left-sided heart failure, they do not tolerate activity very well, so they get easily short of breath. They can't walk very far distances. You may see individuals with left-sided heart failure have cyanosis and hypoxia, pulmonary edema. They may have a cough with a frothy sputum, orthopnea, which is varying levels of breathing, and then you may see some paroxysmal nocturnal shortness of breath. So that can either be that they're stopping breathing and it kind of looks like an apneic state, and then they start breathing again spontaneously. It's paroxysmal, so there's no real pattern in their breathing. So the best way to think about left-sided heart failure is left lung. A lot of the signs and symptoms have to do with lung issues. So if you were to see or a patient were to tell you some of their signs and symptoms and they immediately go to, I feel short of breath and I have this cough that's productive with sputum, and you know that they're having activity intolerance and they're having issues with their respirations, you can see that this may be more directly related to left-sided heart failure versus right. As far as right-sided heart failure, the signs and symptoms are edema and ascites. So ascites is fluid in that abdominal area, generalized edema in that area. You may see peripheral edema, so that's focused on your bilateral lower extremities. Maybe even the upper extremities are starting to swell, but you most likely see this bilateral lower extremity edema. Anorexia, weight loss. You may see some nausea and vomiting with individuals with right-sided heart failure and impaired liver function. So the best way to think about right-sided heart failure is peripheral dysfunction. So, excuse me, you have the edema and the ascites, which affects the periphery, edema that's affecting the periphery. So again, when you look at left-sided heart failure, that's with the lungs. Right-sided heart failure is more so with your peripheral issues. And if you look at the signs and symptoms, they are very similar with that. As far as your diagnostics, you want to have a history and physical examination. They'll also look at a chest x-ray. They may even do a CT chest to look at arteries, or CTA chest to look at the arteries within the heart. You may have echo, telemetry, EKG strips, and cardiac catheterization to help open up things that are occluded. As far as pharmacological treatment, there are multiple. It just depends on how severe the heart failure is. You may have to have surgery. You may have to treat underlying conditions because infection and anemia can cause heart failure. You want to give these individuals extra oxygen. You want to encourage lifestyle modifications similar to that of heart attacks, MIs, or hypertension. And the goal is to correct the cause. And if possible, you want to help improve cardiac output. There are medications that help improve cardiac output. It helps with the squeezing of the heart, and long-term therapy with that. Overall, you want to help improve quality of life. So next we'll talk about a stroke, and this is any clinical event that leads to the impairment of brain circulation, or also known as cerebral circulation. You can have several different types of strokes. You can have a hemorrhagic stroke, which is a bleeding on the brain. You can have an embolic stroke, which is a obstruction, or you can have a stroke that is caused by occlusion of the artery. It normally results in inflammation, ischemia, or even death of neurons. Another thing that we look at with stroke is that sometimes we have actual strokes, which is called the CVA, cerebrovascular accident, and then we have TIAs, or transient ischemic attacks. So cerebral accidents, or cerebrovascular accidents, normally those changes are irreversible and they're permanent, versus with a transient ischemic attack, those tend to resolve with time. As far as your clinical manifestations, you may see this with a focal brain injury or a direct injury to the brain. You may see abrupt onset of hemiparesis, or one-sided paralysis. You may see vision loss or blurred vision, dizziness, ataxia, trouble speaking, aphasia, trouble understanding, or a sudden decrease in the level of consciousness, or any other mental status change. As far as your diagnostics, you want to have a history of physical examination, but because a stroke is emergent, you want to get a CT scan immediately, so that they can be diagnosed with which type of stroke they are. With the types of strokes, you have different treatment methods, so you have to know which type of stroke you're dealing with in order to medically manage it appropriately. So a CT scan is crucial in doing this, and then an MRI can be obtained later to see the extent of the damage. And of course, they'll do different laboratory studies, such as a CBC or BNP, cholesterol levels, things along those lines, in order to determine the source and the cause of the clots, or hemorrhage, or embolism. As far as your treatment, it is emergent. So again, you have to have a CT scan immediately once you have the stroke-like symptoms, because you want to determine which type of stroke it is. You cannot be medically managed if you do not know what type of stroke you're dealing with. Ultimately, you want to reduce cerebral edema and help intracranial pressure to resolve. Now, once the individual has a stroke, you do have to maintain and increase ICP, or intracranial pressure, for a couple of days, because the body has compensated for that occlusion, or for the fact that there is cerebral impairment with the circulation. So you have to keep your pressures high, your blood pressure high, which would ultimately result in increased intracranial pressure. So once the critical period has ended with the stroke, you then see decreases and you start seeing individuals' blood pressure start to level off with medical management and things along those lines. As far as the treatment of stroke, you want to have OT, you want to have rehabilitation, you want to have physical therapy as well to help manage the stroke-like symptoms and help them not progress as far. Here we'll talk about disseminated intravascular coagulation, also known as DIC, and this is the uncontrolled activation of clotting factors, which would result in widespread thrombi from formation. So this is your clotting factors overworking, and when your clotting factors are overworking, you have more production of blood clots. And then eventually there's so many blood clots that the body is having a negative feedback. So the coagulation factors end up decreasing and your platelets end up decreasing, which leads to massive hemorrhage. So you have this initiated by endothelial injury to different parts of the body, depending on the severity, of course. Clinical manifestations are excessive hemorrhaging, bruising, petechiae, nosebleeds, headaches, weakness, seizures, coma. As far as your renal system, you'll see poor urine output and renal failure. As far as respiratory, you'll see cough, shortness of breath, respiratory distress, more oftentimes than not, acute respiratory distress and chest pain. Diagnostic criteria is a history and physical exam, and of course, they're going to look at a lot of your clotting factors. So they're going to look at your prothrombin PT, they're going to look at your PTT, they're going to look at platelets, fibrinogen, D-dimers, and your D-dimer test actually confirms that you have disseminated intravascular coagulation. As far as treatment, you want to correct the underlying cause, and it depends on the presence of hemorrhage versus thrombi or clots. And it is a balancing act between making sure you don't bleed out and making sure that you coagulate appropriately. So again, this is a medical emergency. If left untreated, an individual can bleed profusely and eventually pass away due to hypovolemia and issues with your clotting. So this is disseminated intravascular coagulation. You really want to pay attention to those skin clinical manifestations, easily being bruised, or the petechiae, which is the purple splotches or purple dots on the individual, or maybe red depending on the skin color. But again, when you see that with nosebleeds and just bleeding everywhere, sometimes they bleed from the rectum too, you want to address that immediately. So again, that's disseminated intravascular coagulation. This concludes this lecture, so just make sure you look at the chapter in the textbook and make sure you familiarize yourself with the text. Do your guided learning questions. Make sure you complete your disease disorder cards. Make sure you look at your case studies and activities. Review all of the following with your guided learning questions: the pathophysiology of your clinical models, the clinical manifestations, diagnostics, and treatment. Make sure you're able to understand those application pieces, and make sure you quiz yourself and quiz others. Try to answer those questions in the back of the textbook or in the back of the chapter. And as always, I'm available for questions. So if you have anything, please reach out to me and I'll be more than happy to clarify. Thank you for listening, and I'll see you in the next lecture.